Everybody joins if you can complete the poll question that we launched. We'll start in just a few minutes just to give everybody time to join. Okay, so just in the interest of time, I think we can begin. So thank you all for joining. Really excited to be kicking off this session with some great speakers. As you probably saw, this is a part of a 5-part series focusing on radiation oncology and climate change. And it is my pleasure to introduce our keynote speaker, Dr. Leticia Noguera. She is the scientific director of the Health Services Research within the Surveillance Prevention Health Service Research Program at the American Cancer Society. Her research sits at the intersection of cancer control, health policy, environmental health, and she has a particular focus on understanding how climate change affects cancer risk, access to care, and patient outcomes. We are truly honored to have her with us today to help kick off this series, Why Climate and Cancer Matters. So please join me in welcoming her. And as you go through, there's currently a poll session, if you could complete that. Thank you so much.
Thank you for the kind introduction. Okay, I will share my slides, so let me know if you're able to see them. You never know. I see the poll questions coming in, and it looks like 86% would not know where to start. So before we start the talk, I wanted to share a video with you.
I was diagnosed with bilateral breast cancer. I had a follow-up appointment and an appointment with the oncologist, and the hurricane came. The winds were so high that a 95-foot pine tree went into the bedroom that I had been sleeping in. So I go from sad and stunned and shocked, just scared. A year ago in August, I was diagnosed with cancer, and I was led to this cancer center here and was to begin treatment in early October. But on September 26th, we got hit by Hurricane Helene. The weather report was that we were going to get some rain, and it was going to go towards Atlanta, and it took a sharp turn and went directly through us here in Augusta, Georgia, and this area. It went straight up then to Asheville. We were told basically to have food and medicine and water for 3 days because power might be out. We're going to have some bad wind, and it turned out to be so much worse. Around 3 a.m., I was awakened by some heavy winds, and then a little after 3, the power went out. The barn slammed into the side of the house. The last person I spoke to was my sister, and it was a text. I may not make it. It was something out of a crazy movie. So cancer and a natural disaster of that magnitude, shock and awe.
people have asked me, what was it like being through Hurricane Helene? What did you experience during the hurricane? And I would have to say what's hard for people to comprehend was just the complete and utter collapse of infrastructure. I mean, we lost power, we lost water, we lost cell phone service, we lost landline service, gas stations closed down, grocery stores closed down. There was just a complete collapse. When we started opening up our operations again, I spent all day calling patients, and only about 5% of my calls got through. It actually took weeks before the full stories of what our patients went through began to come to light.
Melissa and I grew up in Washington State. We have two older brothers. We just stayed together for all these years. Everywhere I travel, she'll be 6 months behind me, and here we are in Maui. So August 8th, I was on vacation up in Reno visiting my best friend for her birthday and got to see the devastation on the news.
What we know right now, the county confirmed 2 more deaths tonight, bringing the total to 55 lives lost.
The day of the fire, August 8th, we woke up that morning to hurricane force winds. Trees were down, power was out, communication was very difficult. I could not get a hold of my sister because the cell power was down. So yeah, 7 months after the devastating wildfires, I got the news that I did have breast cancer. It was surreal. It truly was. It happened so fast. She went for a mammogram and they called her on her ride home, asking her to come back and get a biopsy. I was in shock. I don't think I felt really anything. I was just kind of numb, like, okay, it's fine, whatever, I got this. I've been through worse. The fire was the worst thing I could experience, so this is nothing.
It was a nice backyard. My backyard is unrecognizable as even a yard. I don't want to lose my house. I'm trying to get well and get rid of the cancer, get rid of the tumors, but I can't do that till I have a safe place to live. And I'm fighting with the insurance company to get repairs done. Now from all the water, there's toxic mold. I have goosebumps talking about it now. I can't even believe it. It's raw. I'm trying to be healthy and eat well, and everybody's eating, disaster food, canned food. I can't have surgery and recover from surgery in a house that's still broken and leaking. I'm really trying to do 2 things, and I can't do both things at the same time. It's a double trauma.
We had a 45-minute warning to pack a bag. So I packed my suitcase, the medicine, my dog in it, and the Army helicopter loaded us first. My suitcase and my dog were the first to be loaded on the chopper. They did eventually get me to a shelter with mud up to my knees, barefoot. I was happy to be there, but now you deal with this monster of the diagnosis of cancer and the trauma that brings.
And I know for my patients, they had concerns about their cancer. They had concerns about, their medications. What do? I can't get to my doctor. And then we try to triage the patients according to who could have a delay in care without having a significant effect on their outcomes, and who was it critical that we get in immediately.
Anybody going through an after disaster cancer, all of that, all at once, it's a lot. Most of my days, if I wasn't working, I was on the phone with doctors or I was dealing with FEMA, the Red Cross, to get any kind of help whatsoever. Not only was she diagnosed with cancer, but she's asthmatic as well. An entire town right now. So we were worried about toxins everywhere.
A Category 5 has already turned deadly on the islands of the Caribbean. Forecasters calling for Hurricane Maria to make a direct hit in the United States territory of Puerto Rico.
I knew that Maria was going to be a significant impact on Puerto Rico, right? So what we're pushing nowadays is community preparedness, because the first people who's going to help you are the people next to you. So I think that we should invest time, money, effort on helping communities organize. We cannot do this 48 hours before this. Now is the time. We need to think about how we can work together, prepare ourselves across the entire island, nation, globally. This is something that we need to do now.
I hope that helped understand one of our questions. There are currently no specific guidelines to oncology and definitely not to radiation oncology. So why care about climate change in care? There are at least 3 reasons, because there are at least 3 pathways through which climate change impacts cancer care and outcomes. Through disruptions in access to cancer care, through increased exposure to pollutants, and because people who have been diagnosed with cancer are more vulnerable to climate hazards. And after sharing the perspectives of some patients and clinicians, I'd like to tell you about my journey for understanding why and how climate change matters in cancer care. Hurricane Harvey was when climate change and cancer collided for me. I was working in the Texas State Health Department at the time, and I was able to see firsthand the impact that climate-driven disasters can have on communities. Let me explain. Climate change alters the behavior of extreme weather events. Warmer air holds more water vapor, which increases the water capacity of hurricanes. And we could see this with Harvey. This is a map from the National Oceanic and Atmospheric Administration, or NOAA, showing rainfall over Houston during Harvey. And NOAA had to add new colors to the legend because it had never rained so much in one spot before. Now, here's the thing. This was not the first time that Houston had been impacted by a hurricane. The hospitals thought they were prepared. They all had backup generators, but Harvey was different. It stalled over Houston. Then it rained. Then it flooded. Then the backup generators flooded. Extreme weather events can damage medical infrastructure, break transportation links, disrupt supply chains, and interrupt access to medical care. And the changing frequency and behavior of extreme weather events is making it harder for communities to prepare and respond to increasingly unpredictable circumstances, which is especially concerning for medically vulnerable populations who rely on uninterrupted access to care, such as cancer patients. Soon after working on the response to Harvey, I joined the American Cancer Society, and the very first project I proposed was to evaluate the impact of hurricanes on cancer patients. And when I said that, people started laughing. And I'm telling you this because I don't want you to be discouraged from leaning on your lived experiences when proposing efforts on this topic. As more and more of us are personally exposed to climate-driven disasters, the expertise that we gain from these lived experiences is exactly the type of knowledge that we need to tackle such a rapidly evolving crisis. It took some convincing, but in the end, we did run this study that used the National Cancer Database, which is a hospital-based cancer registry that's co-sponsored by the American Cancer Society and the American College of Surgeons. And for this first study, we chose to look at radiation therapy because it's highly dependent on electricity, which is frequently disrupted by hurricanes. It requires the presence of specialized teams, which is also made difficult by hurricanes, and it must be given daily, so the patients have to have access to the facility. Because NCDB collects treatment information, including the dates when radiation therapy started and ended, and the geographic location of the treated facility, we were able to use FEMA data, which has information about presidential disaster declarations, to identify patients whose facility was impacted by a hurricane, and then propensity score matched them with similar patients who completed their treatment at that same facility, but at a time when no disasters happened. And in the end, we found that lung cancer patients whose facility was impacted by a hurricane during their radiation treatment had worse overall survival than similar patients who were treated at that same facility, but at a time when no disasters happened. This turned out to be true for wildfires disasters as well, showing how climate disasters can disrupt access to potentially life-saving care. And disasters can cause disruptions even when they strike far from where care is being delivered. And I learned that lesson when Hurricane Maria hit Puerto Rico less than a month after Harvey. Hurricane Maria caused IV bag shortages in late 2017 when it damaged a major manufacturing facility in Puerto Rico. Then Hurricane Helene did the same thing in 2024 when it flooded a facility that produced 60% of the nation's supply. These repeated events teach us two things. First, if Hurricane Helene was able to cause another shortage in a similar medical product, then it looks like we didn't improve all that much between 2017 and 2024, which highlights the urgent need to develop and implement more healthcare resiliency strategies. And the second lesson is more nuanced. Here's another map from NOAA, this time showing the probability of rainfall in an average year in the areas that were impacted by Hurricane Helene. And Hurricane Helene caused a once-in-a-thousand-year flood in these areas. So the second lesson is that the strategies that we come up with to improve pharmaceutical supply chain resilience cannot assume that any given place is going to be safe from extreme weather events. So this is the first pathway. Then we can see how climate change alters the frequency and behavior of extreme weather events, and that impacts disaster preparedness and response efforts and increases disruptions in access to care. But disruptions in access to medical care was not the only thing I witnessed while working the response to Hurricane Harvey. Turns out that Houston is proud to be the self-declared oil capital of the world, with a high concentration of petrochemical infrastructure throughout the Houston Ship Channel. And Hurricane Harvey's unprecedented precipitation, which climate change made 3.5 times more likely to happen, flooded chemical plants, Superfund sites, oil refineries, and as the flood water went into these facilities and then back out, a lot of contaminants, including carcinogens, were released into the Houston community. And that's when the second connection between climate change and cancer became obvious to me. And that's that our reliance on fossil fuels is a shared cause of climate change and an increasing exposure to carcinogens. Once you realize this, one of the first examples that might come to mind is lung cancer and air pollution from vehicle emissions. The same air pollution that's driving the greenhouse effect also increases lung cancer risk. However, extracting, processing, transporting, waste management of fossil fuels all release carcinogens in communities. This realization was important because most studies were evaluating downstream consequences of climate change, and this unlocked an opportunity to move upstream and potentially contribute to scientific evidence that informs solutions to address both climate change and cancer. We will come back to this later. Let's first take a look at the fossil fuel life cycle. Starting with extraction, take fracking, which is used to extract natural gas, for example. In addition to the methane that is released at the wells, the compressor stations emit fine particulate matter, benzene, formaldehyde, which are all known carcinogens. Then there's the waste that flows back up a fracked well, which also contains carcinogens and is transported by diesel trucks through injection wells, where they can then contaminate water sources. After extraction, there's processing. I mentioned Harvey flooded a lot of Superfund sites. I'm not sure everybody knows what Superfund sites are. This name, Superfund, comes from legislation Congress passed in 1980 that allowed government funds to be used to clean up these super contaminated sites. As you can imagine, whenever government funds are involved, it takes a lot to be considered a Superfund site. This is an illustration of the process from the EPA website. And a quick search of existing Superfund sites will help you understand just how much oil refineries contribute to the rise in exposure to carcinogens. Every other Superfund site used to be an oil refinery. Of course, Superfund sites don't have a monopoly on environmental pollutants. Oil refineries in operation today still release carcinogens in the community, as we saw in Houston during Harvey, but also at the infamous Cancer Alley in Louisiana, and we'll come back to this later. Oh, the Louisiana Cancer Alley is this area along the Mississippi River between Baton Rouge and New Orleans that houses the largest concentration of fossil fuel and petrochemical plants in the Western Hemisphere. This area accounts for about 25% of the petrochemical production in the United States in 2025, and we'll come back to this. Another example of how our reliance on fossil fuels increases risk of exposure to carcinogens is during transportation, and I think we all became more familiar with how this worked when we saw the Ohio train derailment in the news back in 2023. The train was carrying vinyl chloride, which is a petrochemical used in plastic production. It is also an established Group 1 carcinogen. Then there's consumption, which you're probably most familiar with. I usually show pictures of emissions from vehicles because that's the type of fossil fuel consumption we're all used to seeing. But remember that depending on where you live, the electricity powering electric cars and everything else might also be coming from fossil fuels. Then there is the waste, which we don't usually think about. We talked about waste from fracking being injected into wells. And the process of burning coal also generates waste, which is known as coal ash. That's just a catch-all term for several kinds of waste created by power plants that burn coal. And burning coal actually concentrates contaminants like arsenic, chromium, lead, mercury in the ash. This ash is usually mixed with water and stored in coal ash ponds, which have a tendency to leak, flood, and spill, sometimes in catastrophic amounts, such as what happened in Tennessee in 2008, in North Carolina in 2014, and in North Carolina again when Hurricane Florence breached the coal ash pond that contaminated Cape Fear in North Carolina. This last example, of course, with Hurricane Florence, shows how climate change is making these incidents more frequent. We don't have time today to talk about all of the dirty details of each step of the fossil fuel infrastructure, but I believe you've seen enough to understand that each component here releases greenhouse gases, which are contributing to climate change, but also releases carcinogens in communities, which is hindering our cancer prevention efforts. And because climate change alters the frequency and behavior of extreme weather events, making it harder for communities to prepare and respond to increasingly unpredictable circumstances, when disaster strikes, the communities can be exposed to even higher levels of these carcinogens, such as what happened in Houston during Harvey. And these climate-driven disasters can also result in disruptions in access to care. So climate change impacts every single step of the cancer control continuum, including survivorship. Because our reliance on fossil fuels doesn't just increase cancer risk, it also presents hazards to cancer patients, especially young ones. Pound for pound, children breathe more air, drink more water, eat more food than adults, which results in higher levels of exposure to environmental pollutants. Children are also more likely to put their hands in their mouth, and their bodies are still growing, and they're developing several organs functions, so they're less able to process some of these harmful contaminants, which can result in several relevant windows of exposure during childhood. And finally, children also have more time for these exposures to develop into health problems, which is why the EPA considers children a sensitive population that requires special consideration when determining air quality standards. People diagnosed with chronic health conditions, including cancer, are also considered a sensitive population. So in another study, we evaluated the association between exposure to PM2.5 and survival among pediatric cancer patients. PM2.5 is particular matter that is smaller than 2.5 micrometers, which can penetrate deep into the lungs and has been associated with lung cancer and several other cardiorespiratory conditions. In this study, we found that exposure to air pollution above 12 micrograms per cubic meter was associated with worse mortality among children with cancer. And at the time we were running this study, the EPA was considering updating the standard from 12 to 9. However, we found that exposure to PM2.5 at the new standard was still associated with worse mortality among children diagnosed with cancer. Only when the comparison groups were the levels recommended by the WHO of 5 micrograms per cubic meter, then there was no association with worse mortality among children with cancer. So here's the second pathway connecting climate change and worse cancer outcomes. And that all starts with the pollution that we are creating. Anthropogenic pollution is a root cause of both climate change and worse cancer risk and outcomes. After Harvey hit, part of our job at the state health department was to make sense of the health reports that were coming in every few hours and then deploy teams to address the concerns whenever we needed to. Right after the landfall, there were reports of drowning, injury. Then there were reports of infections because people got in contact with contaminated floodwaters, or heat stress because there was a heat wave right after the hurricane and a lot of neighborhoods had lost power, or carbon monoxide poisoning from diesel generators that were being used as backup power. Then there were exacerbations of chronic health conditions because their medicines were lost, or the medicine needed to be refrigerated and people lost power, or the medical equipment had to be left behind or didn't work, or just the stress of it all was too much for people to handle. So extreme weather events also come with health hazards, including extreme temperatures, high and low. This figure shows temperature anomalies during the days after a tropical storm has passed. The point here being that tropical storms are usually followed by heat waves. But also cold. You might remember Winter Storm Uri in Texas. And all types of extreme weather events can cause power outages, especially if you live in Texas, which makes it harder for us to maintain safe temperatures inside our homes. Extreme weather events, especially those that involve floods, also pose health hazards associated with exposure to mold and contaminated water. Wildfire smoke is another relevant pollutant. Here again, it's important to remember that we can be exposed to smoke from wildfires that are burning far away from where we live, as the 2023 wildfire season showed us, when smoke from large fires burning in Canada reached the east coast of the United States. And also pollution from diesel-powered emergency generators that are commonly used during power outages. This is a nice illustration on the EPA website warning about the hazards associated with exposure to diesel fumes, but this is probably a more accurate illustration of this type of pollution. And the health hazards of extreme weather events interact with the physical, psychological, and socioeconomic consequences of cancer and its treatment. Some chemotherapy agents inhibit our ability to regulate our body temperature, which increases vulnerability to extreme temperatures. A weakened immune system increases vulnerability to infections. Changes in employment and healthcare costs also have financial consequences that reduce our ability to cope with the hazards of extreme weather events. Financial hardship makes it harder for us to stockpile food, to be able to evacuate, to adapt our housing infrastructure like using air conditioning or installing air filters during wildfires, all of which cost money. And finally, cardiorespiratory consequences can increase vulnerability to air pollution. In another study, we used NASA satellite data to evaluate the association between proximity to wildfire and survival among patients recovering from lung cancer surgery. We chose to use NASA satellite data instead of on-the-ground air quality monitors because the hazards from proximity to a wildfire go beyond exposure to air pollution. It includes the stress associated with potentially having to evacuate, water and soil contamination, threat to your property, to your life. And these are present no matter which way the smoke plume is actually blown. In this study, we focused on lung cancer surgery because it is challenging for patients to recover from. Complications are common, and recovery may take months. And individuals who were exposed to a wildfire near their home within 6 months of discharge from the hospital following lung cancer surgery had worse overall survival than unexposed individuals, showing how cancer patients are a vulnerable population to the health hazards of extreme weather events. And that's the third pathway through which climate change impacts cancer care and outcomes. The physical, psychological, and socioeconomic consequences of cancer and its treatment can increase vulnerability to climate hazards. So to recap the three pathways, it all starts with polluting human activities that are driving both climate change and increased cancer risk and outcomes. And then climate change makes disaster preparedness and response more complicated, which increases disruptions in cancer care, and cancer and its treatment can increase vulnerability to climate hazards. But before this talk gets too depressing, let's talk about what it is that we can do about all of this. Remember the end of the video we just watched? There are currently no guidelines, so enhancing emergency preparedness and response strategies that are specific to oncology care is one obvious way that we can contribute. There are disaster risk management frameworks out there, and all guidelines related to healthcare mention the importance of continuity of care for individuals with chronic health conditions, the importance of infrastructural resilience, such as backup power, but there is little evidence-based operational guidance for healthcare and nothing specific to oncology. So a few years ago, we decided to look deeper into practical strategies that might already exist. To do this, we evaluated what type of emergency preparedness information is available in NCI-designated cancer centers' websites. Because these are distributed nationwide, are known for high-quality cancer care and research, and are a trusted source of information in their communities. First, we checked, and yes, every single NCI-designated cancer center is in a county that had been impacted by an extreme weather event between 2006 and 2020 that was damaging enough to be declared a disaster requiring FEMA assistance. Then, although we set out to evaluate climate-relevant emergency preparedness information, We immediately noticed that most websites provided some type of information about the COVID-19 pandemic, which was declared a national disaster in March of 2020, demonstrating that cancer centers are able to act quickly on issues they believe should be prioritized. Fewer cancer centers' websites provided information on climate disasters, which have been impacting these facilities since before March 2020, as we just saw. But the important lesson here is that we can do it. COVID was a great example of how much we can accomplish when we come together and share insights. The majority of centers that provided any information had information on steps that individuals can take for COVID and for climate that included creating a portable medical card or pre-registering for a special needs shelter. But I would argue that putting the burden on the individual, especially a cancer patient, to prepare for a disaster might not be the best strategy here. To be fair, some websites also provide information on the steps that the institutions were taking. Especially for COVID, there was really only one strategy for climate, and that was to consolidate appointments during wildfires to minimize the time that the patients spend outdoors. But for COVID, there were several institutional level strategies that were published as guidelines by professional organizations early in the pandemic, March, April, and May of 2020. We could do the same thing for extreme weather events. And technically, we're already halfway there. Having an emergency preparedness plan is already a requirement to participate in Medicare. However, participating institutions are not required to share these plans or the lessons learned trying to implement them with the government or with each other. And this is where we can make a difference and take one step forward. Being able to learn from these experiences is crucial for improving healthcare resilience to extreme weather events. In fact, information sharing is a core recommendation in all of those guidelines. Meanwhile, in the absence of cancer-specific information, empirical evidence, or practical guidelines, it looks like clinicians are already making ad hoc adjustments to cancer care. Imagine you're caring for a patient who received lung cancer surgery, and you hear there's a wildfire around your hospital. You might not be surprised to learn that in another study, we identified facilities that were impacted by a wildfire and found that patients who were recovering from lung cancer surgery had longer length of stay than unexposed patients. This suggests that clinicians may be incorporating concerns about exposure to wildfire hazards into clinical decision-making regarding when to discharge a patient from the hospital. This has several implications because length of stay is a quality of care metric. In the United States, quality of care metrics are used in calculating reimbursement models, how much hospitals and physicians get paid by Medicare. Length of stay is one of these quality metrics because shorter length of stay is linked to better hospital efficiency and lower risk of hospital-related complications, such as infections and falls. When this system was first implemented, hospitals and physicians that were caring for patients with medical and social complexities were being penalized because these patients stayed in the hospital longer. So payment adjustments were implemented to correct for this. But surprise, surprise, there are currently no rewards or bonus points for providing high-quality care during extreme weather events. And this model of social and medical complexities is very much we can replicate this with extreme weather events because there are three factors that determine vulnerability to climate hazards: exposure, sensitivity, and adaptive capacity. Exposure is the human contact with environmental hazards. Sensitivity is the degree to which climate hazards impact humans, and adaptive capacity is the ability to cope with climate hazards. We saw how cancer diagnosis impact people's sensitivity and adaptive capacity already. But people are more than their cancer diagnosis. Due to the way our society is structured, different individual characteristics, including the groups we're racialized into, our gender identity, the languages we speak, socioeconomic status, all can impact our vulnerability to the health hazards of climate change. What do you mean, the way our society is structured? I think the journalist Isabel Wilkinson explained this concept best in her book, Cased. There's a movie too, if you don't want to read the book. Our society is structured in hierarchical layers, meaning that some people are considered more worthy of protection and investment than others. One of the most widely recognized examples of this is redlining, when racial composition was used as part of assessment of areas that were worthy of receiving federal loans during recovery from the Great Depression. When Hulk staff literally drew red lines, hence the term redlining, around communities with large Black populations, flagging them as hazardous investment areas and limiting the options available to these communities. Of course, this strategy of controlling access to resources, especially land, is nothing new, as this map of the indigenous land theft shows. But Hulk maps are a clear marker of how discriminatory policies and practices within and outside of Hulk had long-lasting consequences through systemic disinvestment in communities targeted for marginalization. Historical racist practices included mob violence against Black individuals who moved into white neighborhoods and undervaluing of real estate in Black neighborhoods, a practice that persists to this day. These practices fostered racial residential segregation. And racial residential segregation formed a platform for broad disinvestment in these neighborhoods, including infrastructure like green spacings, house stocks, roads, services, transportation, schools, garbage collection, and employment opportunities. And as we saw, limited access to resources can hinder our adaptive capacity or our ability to cope with environmental hazards. So similar to the socioeconomic challenges faced by individuals who have been diagnosed with cancer, individuals from communities targeted for marginalization also face socioeconomic challenges that make it harder to prepare and respond to disasters. Broad disinvestment in these communities also led to a concentration of psychosocial stressors and created barriers in access to health resources in these neighborhoods, healthy foods. These barriers led to an increase of prevalence of chronic disease burden of individuals in communities targeted for marginalization, including asthma, diabetes, and poor self-rated health. And as we saw, chronic health conditions can make people more sensitive to the health threats of climate change. Neighborhoods targeted for marginalization are also more likely to be exposed to environmental hazards, the third component of vulnerability. This includes air pollution, which is well documented, and even heat, the poster child of climate change. I think we're all tired of hearing about how the temperatures today are the highest that they have ever been. And if you're wondering, that feeling has a name now. It's called broken record breaking. And exposure to extreme heat is one example of the long-lasting consequences of discriminatory policies and practices, because impervious surfaces such as asphalt and concrete trap heat in urban centers, which is also known as urban heat islands. And urban heat islands are more common in previously redlined areas. And now we can start to see how racism is a system with compounding consequences, because if increased exposure wasn't enough, individuals from communities targeted for marginalization are also more likely to have their electricity disconnected than individuals who are racialized as white who receive the same shut-off notice, which exacerbate disparities in heat-related health hazards by decreasing the adaptive capacity of these communities. Now, even if you have air conditioning and you can afford to turn it on, it does not mean you'll be able to use it during a heat wave. The changing climate is making power failures more common. The number of blackouts in the United States doubled between 2015 and 2020, driven in part by high temperatures, which increase demand on the electrical grid as people turn up the AC. These figures show modeled indoor temperatures during a heat wave with the power on and with the power off, such as during a blackout. I'm showing you this data because there's this biased perception that climate change is going to be a problem in the future for those people over there. But climate change is already a problem for all of us. While it is true that communities targeted for marginalization suffer first and most from the health threats of climate change, nobody is safe. And it's exactly because communities targeted for marginalization suffer first and most that you need to include these neglected voices in the conversation. A lot of times when you're closer to the problem, you're closer to the solution. For example, polluting infrastructure is usually developed in proximity to communities targeted for marginalization, where systematic exclusion of these individuals from power structures led to political disempowerment. Take highway construction, for example. Individuals in communities targeted for marginalization are more likely to be exposed to air pollution due in part because highway construction was a tool used for racial residential segregation. It was also called white men's roads through black men's homes. Highway construction prioritized transportation of white individuals who had privileged access to property in suburban residential areas. The highways targeted predominantly Black neighborhoods, demolished property, and forced businesses to close, again, limiting access to resources. Unsurprisingly, individuals from communities that were targeted for highway construction and therefore have been closer to the problem are now leading neighborhood reconstruction efforts aimed at removing this type of infrastructure. These efforts have implications for climate change because highways prolong our dependence on fossil fuels, and for public health because, again, while it is true that individuals residing in neighborhoods that were targeted for highway construction are disproportionately exposed to air pollution, you cannot tell air pollution to stay in one place. So highway removal reduces exposure to air pollution in the entire population. If we understand that our continued reliance on fossil fuels is at the root cause of both climate change and increased exposure to carcinogens, then we understand why supporting environmental justice effort is an integral part of our mission. The lowest hanging fruit here when it comes to upstream solutions. Remember the Louisiana Cancer Alley, the expertise that was developed by residents who had lived experiences with the health consequences of petrochemical pollution led to strategies such as opposition to expansion and continued permitting of the Formosa plastics plant that are relevant to all of us because it targets the root cause of both climate change and cancer burden. And we can learn from these insights and incorporate this expertise in our own activities. The healthcare system is the second most energy-intensive industry in the United States. Emissions from the United States healthcare system alone exceed emissions in the entire United Kingdom. Increasing use of clean energy sources, especially those that are generated on site, can reduce the environmental impacts of institutions and also make them more resilient to power outages that are only expected to become more frequent with climate change. Our understanding of the full range of benefits of clean energy sources generated on site is also coming from communities that are being impacted first and worst by environmental hazards, because after Hurricane Maria devastated the electric grid in Puerto Rico, island residents have been leading efforts in developing microgrid systems, which improve resilience to power outages because, unlike diesel, microgrids don't need to be transported, so they're more resilient to disruptions in the supply chain. Also, this is what a diesel-powered emergency generator looks like when they're not flooded and they're working properly. So a shift towards clean energy sources that are generated on sites also reduce exposure to surrounding communities to toxic air pollution during emergencies. And if you're thinking, well, yeah, but the hurricanes are going to blow the solar powers away. There's technology developed to storm-proof solar power systems, most of which is coming from small island nations in the Bahamas, where these technologies were developed after Hurricane Dorian and Irma left the island without power for over 100 days. So this is another example of solutions that address both downstream consequences of climate change or adaptation resilience to power outages and upstream consequences upstream causes of both climate change and cancer. That's not the only one. Air pollution is just one of them. Take a look at our food system, for example. The industrialized food system is responsible for approximately 40% of greenhouse gas emissions globally. Usually people focus on the environmental impact of meat, which has the highest environmental impact no matter how you measure it. If you consider the emissions associated with the production, processing, and transportation of feed, just what the animals eat, then the methane emissions by the ruminants, then energy consumption at feedlots and slaughterhouses, the amount of antibiotics, pesticides, and the amount of waste generated by the animals. Then it's easy to understand why the environmental impact of meat production is so significant. But it's not just meat, right? It's the industrialization of the food system that is the problem here. This type of food production that relies on land clearing, monocultures, heavy machinery, processing, packaging, external inputs, herbicides, pesticides, fertilizers, they have environmental and health consequences, especially if you consider food additives, coloring, emulsifiers that these foods contain. So the sentence that we usually say here is that it's not the cow, it's the how. Industrialized food production is also impacting our health, and now we're starting to better understand these impacts of consumption of ultra-processed foods. Because there's so much overlap between climate change and cancer control solutions, we recently evaluated the inclusion of climate change solutions in comprehensive cancer control plans. There are currently 65 states, territories, and tribal health organizations that are required to have a comprehensive cancer control plan because they receive funding from the CDC. Of the 65, 2 included just the words climate change, Alaska, and Illinois. But when we looked at the actual cancer control strategies that these plans had, more than half had at least one that was also relevant to climate change, and several of them had more than one. These included disaster preparedness. Louisiana was one of them, unsurprisingly, given Katrina. Also, climate adaptation strategies that are relevant for cancer preventive behaviors, like providing space for walking clubs when the weather is inappropriate, or planting trees. Trees' cooling capacity is not only due to shade, but also transpiration, which further decreases local temperatures. Think about the difference in temperature when you stand under a tree versus under one of those man-made concrete shade structures. And trees also allow the creation or improvement of stormwater systems because the soil around the trees help with water infiltration, which can help reduce flood risk. And of course, it's a green infrastructure that also cleans the air. So planting trees was mentioning a lot of the plans, and sometimes as a strategy to reduce exposure to pollution, which we also talked about. And again, with the strategies coming from communities targeted for marginalization in neighborhood reconstruction are a great opportunity for increasing green spaces in urban areas. Also, several plans mention strategies to incentivize active transportation, which of course increases physical activity and reduces pollution from vehicles. And the most common was actually about the food system, and including strategies related to reduce reliance on this industrialized food system, community gardens, farmers markets, reducing consumption of ultra-processed foods, agreements with local food producers, and including traditional foods in dietary guidelines. And this overlap between climate change and cancer control solutions is really what makes me hopeful. Because in the end, we have 3 choices when it comes to climate change: mitigation, adaptation, or suffering. The more mitigation we do, the less adaptation will be necessary, and the less suffering there will be. And there is something here for each one of us to do. We can research how environmental responsible policies and practices at our institutions where we live can impact health outcomes, or champion these efforts at our institutions. We can contribute to improving emergency preparedness and response efforts. Of course, nobody wants to contribute to suffering, but suffering is already happening, and we can document it in a manner that increases awareness and informs solution. We have a list here of some of the strategies that you could champion at your institution. If you're looking at this list and thinking, this lady is crazy, there is no way my institution would ever even look into any of these. Let me ask you something. Are you allowed to smoke on campus? How do you think that happened? How do you think that started? If you're here today, you most certainly have the power to make a difference. So use your leverage, move the world. Thank you.
Thank you so much, Dr. Nogueira. Yeah, that was an incredibly inspiring and educational presentation. So we have about 10 minutes left, and wanted to open it up for any additional questions that people might have. And if there's no questions right now, I can start. I was curious, so like coming from the perspective of an oncologist and radiation oncologist, any thoughts or recommendations on like how we proactively identify these individuals, patients that are within kind of these marginalized groups that might be at higher risk for climate-related disasters to be impacted by those events? Is it these vulnerabilities? Is it something that you commonly see and screen for? And if so, like what are the kind of actionable next steps to really kind of be proactive in that space for those patients?
It's a great question. And so there's several different angles that you can come at this. I think that every time we go, or at least I go to the doctor, there's the questions. do you drink? Do you smoke? But rarely ever anybody asks, are you concerned about any pollution around your house? Do you have an emergency preparedness plan? Do you an evacuation plan, right? Especially now, hurricane season, wildfire season. And I think that asking about these might be one of the first steps. It probably will be a long journey until it is customary or that it's included on electronic health records, but it has to start somewhere. I think there's also a push for leveraging the information that is already collected. We have patients' address that could be linked with several different sources of environmental vulnerability and have that be a flag in itself that requires zero additional effort from clinicians. So that's another important perspective. Then there is the actual diagnosis codes that we could use. If we know somebody is receiving insulin or is dependent on insulin dependent, and there is an event coming. Wildfire is usually not as much, but hurricanes will give you a few days to prepare. And so I think that facilitating either pre-registering for a shelter or like some patients who are recovering from surgery or prescribing in advance and then double checking if the patients will have access to refrigeration, if that's the medication that's necessary. So I think leveraging some of the diagnostics and procedural codes to identify patients who might benefit or might be at increased vulnerability and benefit from some assistance are some of the strategies that are being discussed.
Oh, that's great. And curious, just have you seen any hospital systems to successfully integrate those into an EHR system yet, or not yet?
I haven't seen a hospital system. I haven't seen that be. I think that awareness of how frequent these events are and how much they impact patients is just starting. Most of the health consequences of climate change have been discussed as increasing infection diseases, not so much exacerbation of chronic health conditions. So I think that it's still in the beginning, but whether we have seen a lot of success is with chronic kidney condition because dialysis is needed such a frequent event that several of the dialysis centers here in Florida, for example, works together when Hurricane Ian was about to make landfall and prepared in advance and mapped out with cell phones where the patients were and were distributing messages as asking patients to come in early and buy some time by having their dialysis right before Ian hit, and then phasing out as the dialysis centers were reopening, which patients were first in line to the closest one. And so there is some evidence of strategies that have been used in other specialties, but I think that especially when it comes to oncology, we haven't seen a whole lot of development on this.
Thank you. Any other questions from the group?